Hi, welcome to the Jewish Orthodox Women's Medical Association podcast. I'm your host, Elisa Minkin. I'm a general pediatrician and proud member of JOWMA, and I'm really excited to be here today with another proud JOWMA member, Dr. Hindi Mermelstein. Hi.
Hi,
Thank you so much for being here tonight.
it is my pleasure.
Yes, we've been trying to do this for a long time, so we're very excited. Dr. Mermelstein is an adult psychiatrist with added specialties in geriatric psychiatry and Consultation-Liaison psychiatry, psychosomatic medicine. She completed her undergraduate degree at Touro College and was the first female graduate to go to medical school. What a trailblazer. That is amazing.
41 years ago.
Amazing. She obtained her MD degree at SUNY, Upstate College of Medicine, followed by an internal medicine internship at the Beth Israel Medical Center, a psychiatry residency at NYU-Bellevue, and a fellowship in the Dept of Neurology at the Memorial Sloan Kettering Cancer Center. She has served in a variety of clinical, administrative, and academic positions and has been involved in a number of community and professional organizations, including JOWMA, and is currently the chair of Standards and Ethics Committee for the Academy of Consultant-Liaison Psychiatry, as well as the Community Practice SIG. What does that stand for?
Special interest group.
Thank you. She currently splits her professional time between her positions at NYU, Northwell, and her private practice. Wow. I'm always impressed. This is not our first podcast. Thank you so much.
It sounds much more exciting than it is.
No, it's awesome. And so you're really in a good position to talk about something that's really, I haven't talked about adequately, and I feel bad about that, which is how our older members of our population are faring during this pandemic. And I want to address this to them and to their family members. So I'm going to just let you talk and start with just putting it in a perspective, because we were originally going to talk about just aging, and now we really have to put it in the context of the pandemic.
Of course we do, because everybody has been impacted by this by the pandemic and by the shelter in place that took place, that originally had to take place, and by the struggle that has gone on for over a year now. You know, everybody, each of us has found ways in the course of our lives to handle acute crisis. You know, you're acutely sick, or you have an acute or there's something that happens immediately, and we found a way to handle it because the rest of the world goes on. And so we go on pause, the world continues, and then we pick up when we go off pause. But the pandemic changed all that. The pandemic, we all went on pause. And there was very, very little that happened that didn't affect every single person in parallel, meaning society structures, communal structures, individuals, and families all struggled with similar issues. You know, individuals that did not know about how to handle intimacy. You know, I tell everybody, I have a daughter who is a nurse, and she was living with us at the time when the pandemic started, and she asked us if she should move out, because my husband and I are a little bit on the older side, and I got medical illness occurs in our household. And I said no, we were thinking about that the other day, because she was vaccinated and I was vaccinated, doubly vaccinated already by the end of January, and we did not hug and kiss until about a month ago.
Oh, wow.
You know, in other words,
so careful.
He's so careful. So, and I'm, as you, Dr. Minkin, know, I've been a big proponent of reentry early on.
Right. Let's say when we say reentry, right? I remember we did our talk, and it was after they had said, flatten the curve. You'll just stay home for a while and you'll flatten the curve. And we flattened the curve. And then we had to talk about reentry coming back.
Right.
So much has happened since then.
Well, a couple of things have happened since then that I think have really added to the burden of COVID and added to the burden of everyone in society. And I'd like to tell you particularly those that are older, particularly older folk, because they have struggled with being absent and being isolated. So I will sort of go back to what I originally started my spiel about, and that is COVID has affected everybody. And not only did we have the talk about reentry relatively early on, when they said flatten the curve, and they flattened the curve, and they talked about reopening, and the summer looked very promising, and then there was a second surge,
Right.
and then there was a terror about the surge, and then there was a debate whether or not we should stay closed or open. And since then, we have been on extended pause again. And the difference now is that we are actually in a place where we can begin to truly reopen, and yet we are still, as people and as society, stuck in pause. And I'll explain that in a minute. But meaning, using the example of my daughter, or using the example of a friend of mine who unfortunately lost her parents, and she was not sure whether or not recently, not due to COVID, or at least not directly due to COVID, and she was not sure whether or not people should be able to come to the funeral. Everyone who would be at that funeral was doubly vaccinated. They were not talking about a large group, but still in all, there has been such fear of connection and such hesitancy of socialization that even though on medical and scientific grounds, and it was outdoors, on medical and scientific grounds, she could have had more than 10 people at the funeral, she was hesitant.
But I mean, I think that's what we talked about in our reentry talk, that different people were going to have different risk-benefit analyses.
Right. Well, the world
That's okay, right? That's okay.
Okay.
Except when it's mandated to be super safe for everybody. That's all separate.
No, that is okay. But what I am going to urge is that as the fear of reentry begins to be split off from the possibility of reentry, that we have to be careful to help people reset realistic risk assessments. Everyone's got different ones. Everyone's got a different risk tolerance. Everyone's got a different concern. But I am worried that as things have become safer in many ways, and we'll talk about that in a second, medically and psychologically and socially, especially among the aged or the older population, that we help usher people back to a reset, and then they can use their regular risk assessment. Meaning, go ahead. You were going to say.
What I'm thinking is that I think everybody's very aware that the older you are, the greater the risk COVID poses to you, right? So, for example, I'm 74 years old, and I want to know, now that I've been vaccinated, can I dance at a wedding? Can I hold hands at a wedding? Can I hug people at a wedding? And we're talking about a 74-year-old who's been vaccinated, but is talking about high-risk behaviors. Presuming this is, say, a 200 or 500 or whatever person wedding, not a 10 person or 20 person or,
right,
person close friends wearing masks versus not wearing masks. What I'm saying is that I think that there's a certain rational caution here.
There is caution. Look, COVID has not disappeared, right? Caution has not disappeared. But what we talked about when we did the reentry, the reading risk tea leaf talk originally, and what was still true was that there needs to be a cost benefit analysis to everything we do. And that's really what I think we should focus on. Do I think that a 74-year-old who's in good health and is doubly vaccinated is a different person, is a different situation than a 74-year-old who has other risk factors for doing poorly if they should get COVID? Of course I do. Do I think there needs to be inclusion in that assessment of the fact that post-vaccination, even if someone contracts COVID, because there is still some risk of contracting it, there is some very small but true reinfection risk. It's very small. The chance of having a serious case of hospitalization and death has been declined even further. So let's look at that for a minute. If you've been doubly vaccinated, the chances of contracting COVID have become much lower. Whether it's 60% lower or 90% lower, or 92% lower, and when you include the variants or not, I'm not talking about the number exactly, but I am saying that we reduce the risk of contracting COVID by a fair estimation by 3/4. Approximately.
It's significant, but you just don't part you're in of that calculus.
Okay, but very significant. We've at least halved it, and probably more than halved it. We can agree on that, I think. And then we have to add the other probabilities. The other probabilities are that even if you were to contract COVID post-vaccination, the risk of hospitalization has gone down dramatically, and the risk of death is even further. So what we're taught, when we originally were going, we just sheltered in place and went on pause to flatten the curve.
Mm-hmm.
The curve we have now flattened is the risk of death from COVID.
Right.
And the risk of serious illness from COVID.
Right.
It doesn't mean that,
we have to live with it being here. We're not going to eradicate it, and you can't stay in your home until it's gone.
You can stay and if you stay in your, it's safer in your basement or wherever in your home, under your covers if you're me. It's safer in theory, but it's actually much, much more destructive. And that, going back to the aging issue, individuals who are older are more dependent than those who are younger on social structures and connections. In fact, their job in society, if you talk, is to actually shift some of the active work to the connected work. What do I mean? There's a point in time, where traditionally, let's say, children decide that parents should not be making the holidays for all, and they take over that job. When COVID hit, and parents and children and grandchildren could no longer get together, they lost that whole connection. They lost that structure. One of the ways that aging people who have some sort of cognitive decline, and we're not going through the details of what the cognitive decline is, but cognitive decline, one of the ways of treating it, one of the ways of avoiding further decline is social connections and social affability. Keeping structures exactly the way, going to shul, or going to synagogue, or going to the JCC, or going to the Senior Citizen Center is a very, very active and very constructive and very, very necessary part of health and well-being for the aging and the elderly, and COVID put a stop to that. I have a friend who builds housing, and much of her housing is housing for the aged.
Mm-hmm.
And in all her buildings, there was a senior citizen center where they served lunch. When COVID hit, the city of New York, or maybe the town, or maybe the Nassau County, I don't really know which one, closed those senior citizen centers for safety, and instead had the food delivered to the elderly people. However, what really happened is that they stopped eating.
Oh.
Because people came to the senior citizen center for connection and for socialization and to encourage each other, and delivering it to their home. They then had to have someone cook it for them or prepare it for them, as opposed to have them served. They lost the opportunity to have to take care of each other. And so in the effort to save them and keep them safe, they actually hurt them. You and I both are physicians, and we both know that there's tremendous excess mortality, excess deaths related to COVID, not because of COVID directly, but because people are so afraid they haven't been going for their regular checkup still. There was an article today about the problem they have about colonoscopy. I deal with older people, so I deal with colonoscopies, okay, as opposed to the typical children vaccines that were also delayed. So there's a screening test called Cologuard, but if there's an abnormal finding, you're supposed to go for a colonoscopy within a year. Well, the number of people that have gone for the colonoscopy within a year has plummeted. And we know that colonoscopies is one of the few things we have in our hand that really saves lives, because we know that treating polyps, for example, early, or finding colon cancer early is life-saving. So in an effort, those are two examples, too many words, but two examples whereby in an effort to keep people safe, we've actually harmed them. And the reason this is important is because you're right, everyone has a different risk. And you're right that everyone wants to keep everybody else safe. And so they're taking care of each other, but in a way they're keeping themselves safe, but actually preventing them from living.
Right, because there's risks to not doing things.
There's tremendous risk to not doing.
Especially as we go so long. You know, if you're doing it for a short period of time, like remember we talked about pause, a few months, and then life would resume normal. We don't even know what that normal was anymore. And I'm really wondering what we are seeing as a whole in the older population. I know that in children, I'm seeing a tremendous increase in mental health problems.
In the older population, we're seeing a lot of people that have become the number of people that have become tremendously demoralized and depressed. But and the number the people I have seen in my practice have aged dramatically over these last few months. They've aged in place. The original title is, they've aged in place without their normal activity. Because also think about it, you and young people, even if they're in Zoom school, they're in Zoom. Older, middle-aged people or have some sort of work environment, even if it's remotely. Older people often are very dependent on activities that are connected to the outside. It helps keep them active, keep them connected, keep them structured, it helps give meaning to their lives. Everybody needs meaning in their life. And in the absence of that, that's the number one thing I've seen in my practice. Not only are they demoralized, but people have aged dramatically. They've stopped coloring their hair. They've stopped buying clothes. They've stopped doing all those things that kept them young or kept them feeling young. And you're right. I started talking about acute, about when we originally went on pause, we originally went on sheltered in place, it was supposed to be temporary. The difference between acute and chronic, or temporary and not temporary, is that when acute, you can do anything. You can tolerate anything for a short period of time, and then, essentially the world goes back. At some point in time, you have to begin to think about how to integrate, how to incorporate reality and figure out how to incorporate it and make it part of your life. COVID is not likely to be going away. The flu is not likely to be going away. And we've managed to find some way of handling it. And I think that our job now about reentry is not only, it's the job now to reentry is exactly what you said. The job we have now, the task we have now is to help, I guess, patients, help individuals understand that waiting for it to disappear or waiting for an absolute risk-free, safe place, waiting to avoid the possibility of COVID is going to destroy what's present, because it's a goal that's not possible, and the cost of that is multiplying on itself.
Right, and it's true that even for our oldest members who've been vaccinated, even if it's not perfect, we have them, and we have masks, and we have distancing, and we have monoclonal antibodies, which are amazing for our high-risk population. So we didn't have anything.
No, I'll give you a couple of clinical examples in real time. 94-year-old man got one vaccine and was going to get a second vaccine, and he had a visitor and he ended up contracting COVID. Okay. But because he was 94, he went to the hospital prophylactically, just preventative. But because he already had one vaccine, the thought is that he had a mild case, relatively mild case. They're able to use monoclonal antibodies, and within day 3, he was fine.
It's amazing.
Amazing. That would not have happened if you look at the number of people that end up on ventilator. Even without that, we know how to handle it better.
Right.
And so you think
about being inundated, we don't have the problem of having our resources stretched to the point of not even
we don't.
Supportive care.
No, we don't. And we understand a lot more about how to handle the condition when it happens, so that the outcome is better even before vaccines. So what I'm urging, what I'm suggesting, inelegantly maybe today, because this is a human talk rather than a medical talk a little bit, But what I'm urging is I'm saying that the aging in place, the shelter in place has affected our older population much harder than anybody else, in part because they're in transition, in part because they are the most dependent on the connections that we have and the structures that we have. It's hard to be in a pod. It's hard if you're in your family to be in a pod, connections within, but you're still sitting. There are two of you, three of you, four of you still sitting around the Shabbos table, still sitting around the dinner table of any sort, still involved in. If you are a widow in your house, you don't have that.
Right.
If you are a couple who have transferred a lot of the action, a lot of the social action, a lot of family action to your children or to other members of society, and it's been been taken from you, what are you going to do? If you can't, if the synagogues and the community centers and the senior citizen centers are not open, there's not a place for you to do that. And they are actually hidden. A lot of older people don't even know that they're hidden. People worry about their food, but don't worry about their socialization.
Mm-hmm.
It's caused tremendous aging in place. It's caused tremendous demoralization and depression. It's caused premature. I've also tell you, it's also caused a lot of people to just stop. Patients have stopped even thinking they're going to go back to volunteering. They're going to go back to their job. The number of older people who have retired or not planning on going back is very high. COVID is still here. You still have to be cautious. You still have to be thoughtful. You still have to be cognizant that there is risk. But we also have to be much, much more aware, supportive, and encouraging for people to understand what risk is, that there's risk of not doing as well as doing, to calculate risk and to incorporate risk to be able to move forward and reconnect and reestablish those structures that we all need, older people particularly.
And I think this is true also for family members.
Yes.
Right, for them to be able to not hold their loved one back or let them be too isolated because they're afraid, they want to protect them, to understand the risks, right, of being too safe, right, of erring on that side. Because when you err on one side, you're losing out on the other side. I have to say this before I don't lose my moment. I'm going to put a big plug in for having everybody around the elderly person vaccinated, because this really does come up. People who are not being careful and they're just not thinking that their choice is going to affect their parent, grandparent, whatever.
And the final reason, and the plug for that is that even if something should happen, you want to be there. This is probably, I have one of the security guards at one of the jobs I have, his mother died. Mother died maybe of COVID or maybe related to COVID. And he was very, very grateful that his mother took care of him. How does mother take care of him? She waited to die until he was allowed to be present at the funeral.
Oh.
And I'm closing with that to say to say in indirect way that actually getting vaccinated, learning what the risks are, learning how to take care of the risks, but not to be afraid, will do a tremendous amount towards restoring and reestablishing and taking care of the very people we love.
Right. Do you want to talk about how to recognize when one of your relatives is starting to decline, and how to tell what it is? Because you mentioned before that many are just getting depressed.
Very demoralized. Well, the difference, I guess the difference is people who are, it's like being significantly depressed. The truth is that people who are cognitively impaired because they have a neurological condition, it doesn't matter what circumstances they are, they're still cognitively impaired.
Okay, so you see your relative, your elderly relative is not doing as well. How would you think the pandemic would change things? Say they're not living in the same home as you. Obviously, if they're
Well, I
living,
guess excuse me?
if they're living in the same home, you can watch it. I'm just wondering what it's like for someone who's not.
It's very hard. I think, I mean, you know, I would say to you that if you think that your elderly relative is not doing as well, I think that I'm going to make a plea that may not be popular with everybody. And I'm going to say that is an example of where the risk of not doing is maybe greater than the risk of doing. If you think someone is not doing as well, I literally wrote a prescription for someone to come out of isolation because I thought that they were so depressed and so demoralized being isolated that I thought that we were doing them harm. I had a family meeting for just explaining that, you know, and you see with children too, I'm sure. You see it with, there was a group in the Midwest of elderly people that live in assisted facilities that actually sue the assisted facility for not letting them have visitors.
Oh, wow.
Because they said that they should, well, you know, they should have the right to make that decision, but also the cost of not having someone to look in on them was much greater. So to answer your question indirectly, which I did not ask it directly.
Mm-hmm.
I think you have to do I think when you're not with them, you have to do a much more careful assessment of what's going on. Are they not doing well because they're not active? Are they not doing well because they can't remember to take their medicine? Are they not doing well because it doesn't matter to them what time of day it is, and not doing well because they're not active during the day and therefore they're not sleeping? In other words, we have to replace questioning and investigation with observation. You have to replace that for what normally you use, which is observation. We normally are with people and there you can get an idea. If they live with you, they don't live with you, you get an idea. You know, you see them, you know them. If you can't see them and can't be with them, you have to ask them. You have to inquire. You have to be much more attentive to the cues that you know. One patient I had whose mother just was complaining the refrigerator didn't work. Why? Because the daughter would deliver food and the mother was not interested in eating, so she wouldn't eat as much and the food got spoiled.
Aww.
Okay, that's an extreme example, but you're asking how you tell. You have to replace observation with inquisition, with questioning. Inquisition is too harsh a term. And you have to be very alert and very, I guess, assertive about investigating things that you think are not okay. If you're worried, then assume that there's reason to worry, because you don't have the ability to get enough information to discount that concern.
And now I'm going to flip it around to talking directly to people who are getting older and saying, am I getting dementia? Forgetting things all the time. I'm in a fog. I just want to say someone coined the term corona fog, and I've been using it ever since. I have not been thinking as clearly.
Well, you've not been thinking clearly because the demoralization that I talked about before is going on for all of us. Right. I mean, you know, I don't know about you, but it's much harder to keep track of what day of the week it's going to be, or what holidays are coming up. Or I can't imagine that it's going to be Shavuos in 3 weeks, because I don't know where the time went, because the time doesn't have the same meaning. It all has become in sort of this I was saying morass, but that's not true. But it's all become in this sort of, I'm not sure what. It's been an ill-defined, odd existence over the last year.
Right.
And we need the structures in our lives. We need the normal activity to keep ourselves to attach to. And the absence of that, there's a lot of that going on. So we're all affected by that. However, how do you tell if someone is developing dementia? That's really the question. And the question is that question is probably what drives most people into my office over a certain age. Because most people are not so much afraid of dying as they are afraid of being disabled. And never mind being disabled, being demented is the worst. The number of people that come in because they're afraid they have Alzheimer's is quite high. As we age, as our bodies age, as we become creaky and cranky, our brains also age. And there's certain things that are normal for us to age. Our reaction time gets slower. Our short-term memory that's not attached to something gets worse, you know. How many times do I go downstairs to my basement and not remember what I went downstairs for? Have to come back up to remind myself about why I went down, which is why lists become more important, Post-its become more important, all those things. Okay. One of the things that's very noticeable and probably scares people most is this issue about retrieval. You know, you're sitting with someone and you know there's a word you want to say and you can't remember what the word is, and you think to yourself, oh my God, I used to be a wordsmith. I used to be able to retrieve words all the time, or even worse, somebody's name.
Right.
And my answer to you is that retrieval is part of normal aging. As long as it comes back to you, as long as sort of like, 3 hours later, you say to myself, oh my God, of course I knew that word. How could I forget it? That's okay. It's scary, but that's not dementia.
Right. And it might be that with COVID and with that corona fog that they may add another layer and you may not remember it, but you're still okay, right?
Right. The corona, right. So that's normal without this. And then if you have stress, or if you have fatigue, or if you have demoralization, or if anything else is getting in your way, because if you think about it, memory is a learning function. In order to remember something, you have to have paid enough attention to take it in, to encode it, to store it, and then to retrieve it, and then to express it. Oh my God, those are so many steps. Anything that interferes with that, usually originally the original focus to learn it, to pay attention to it. So anything that interferes with your attention, if you're tired, if you're distracted, if you're demoralized, if we're sort of in the middle of this corona fog because we've been living this odd experience, it's much harder to pay attention and the type of attention you need in order to create a memory that you can then retrieve. Mm-hmm. So any of those steps, and many of those steps slow down as our brains get older, and that's not dementia. Dementia is actually a medical condition that is distinct. The good news is most people are not demented. The good news, the number of people that grow older and do not develop dementia is overwhelmingly true. It's age related, but it's not age. It's not age determined. Meaning, if you're 70, or if you're 80, or if you're 85, not everyone who's 85 has dementia, and everyone who's 90 or 95 has dementia. You do have normal changes with aging. You do generally, the older we get, we generally have less reserve, meaning there's a condition called minimally impaired cognition. Don't you love that term? Yeah. All that means is that normally day to day without corona, okay? Please, before corona.
We're all minimally impaired, at least.
We're all, but before corona, that essentially you could function normally without any signs, but you were much more vulnerable to stress. So if you're trying to do multiple tasks, most of us actually, if you're trying to do multiple things at once, you can't. Now, in truth, none of us can. We really don't multitask. We like to think we do, but actually what the difference is that normally when you're younger and spry, this shifting between one activity, this shift set is so rapid, it feels like you're multitasking. When we get older, that slows down, and all of a sudden we feel like we can't multitask, that we recognize we have to do things sequentially in order. So minimally cognition is actually there's some brain impact, but it's really an impact of reserve. That's the way I think about it, the way I explain it, so that you can function normally day to day. But if you're overly stressed, if things are overly complicated, then you find that you're not able to function. Small percentage of those people go into dementia, but again, it's not deterministic. Not everyone who develops mentally impaired cognition becomes demented. Mm-hmm. And so it's annoying, it's problematic, those people are the people that need help, that hire someone to do their bills, maybe, need help or need assistance in things that are not day-to-day normal day-to-day activities, but they don't necessarily progress, and they don't necessarily, it doesn't predict for dementia.
Are there preventative steps along the way?
Um,
I've heard of things
like
like puzzles, crossword puzzles, staying active, getting enough sleep, eating a healthy diet.
anything that improves your health and well-being will improve your brain health, because our brains are part of the rest of our bodies.
Mhm.
So anything, so sleep and healthy diet is good for your, it's good directly and indirectly. It's good directly because it's good directly. It's good indirectly because the same things that predict for poor, predict for clogged arteries in your heart are going to predict for clogged arteries in your brain.
Mhm.
So that's true. And there is some thought that things like exercise are things like, as a perfect example, help do one more thing. And that is, in order for our brains to function optimally, we have to be, the ends of our brain, of our neurons, of our nerve cells get worn out. They have little fibers that get worn out at the ends. And in order for them to, our brains to work optimally, those nerve fibers have to be replaced because they get, worn. So, anything else, like sort of like,
Yeah.
they get frayed. They do. They literally get frayed. And there are many things that can promote that kind of regeneration or that kind of new growth. A brain neurotropic factor, and we think it's exercise. We think that there's some diet, there's some medication. So in that sense, there are multiple ways, anything. But probably the two most important things in addition to that are activity and social connectedness.
And now we're back to the problem of the pandemic.
We're back to the problem. It comes back full circle. And that is, your plea was for vaccinations, and I support that. Yes, yes, yes.
Yes.
And my plea is to recognize that keeping someone, you have to think about how you're keeping someone safe.
But that would be connected because through vaccinations of the person and everyone around them, you're keeping them.
Right, you can have both. You can have best of both worlds, right?
Right. No, they're interconnected. We both agree.
Of course, you can keep people safe and you can protect them from being unsafe.
Right. I think, I'm sorry.
No, go ahead.
No, I was going to say that I think that that's a really good place to end, because I don't think we really, at this point in time, and maybe part two, need to go into a deeper layer of the dementia. But in terms of the preventive aspect, and I just feel like it's enough for the pandemic to encourage people, get vaccinated, get yourself vaccinated, have your people around you, and also people who work with you. Right? If you have AIDS and the AIDS aren't vaccinated,
it's tremendous issue.
Risk. And I would put a plea out, not to push, but to gently encourage and have them, get good sources of information so they can choose to vaccinate, so they can get you out there, out in the world, get you back with your friends, and, and back to structure and activity.
Mm-hmm. And connectedness.
And connectedness to the family, absolutely, and to the community.
So I agree. Thank you for this opportunity.
Thank you so much for doing this with me. We'll have to do part two at some point.
Okay. Bye-bye.
Thank you.
Bye.